As cataract surgeons, we often gain access to the lens via the cornea. So we have to be careful that our intervention may lead to corneal infections with cataract surgeries. And how can we prevent, manage, and avoid disaster with our cataract surgeries? Well, as we talked about yesterday, endophthalmitis is one of the most feared complications, fortunately rare, but potentially devastating, that can interrupt an otherwise successful cataract surgery like this combined phacoemulsification with posterior chamber intraocular lens implantation and trabeculectomy that went well except for Enterococcus faecalis that complicated matters, and this eye went to no light perception. It's interesting, despite all these advances we've been talking about for the last couple of days, the incidence of endophthalmitis may actually be increasing. And is it due to the evolving preference, the standard, if you will, for clear corneal, quote, self-sealing incisions? This is a look from the article in Japan that showed a 4.6-fold increased risk of endophthalmitis with temporal clear corneal incisions versus superior scleral corneal incisions. And this was a prospective, well-designed study that was conducted by Nagaki and colleagues from some years ago. How is it that these infections occur? Well, it's been proposed that this is an India ink simulation of bacteria migrating along the tract of the wound. As cataract surgeons, we worry about a spike in intraocular pressure, a postoperative glaucomatous elevation, but really we should probably be more worried about transient hypotony, which may occur, as Brad Shingleton reported, in about 24% of cases that can lead to the wound opening and a problem with bacteria tracking along the incision into the eye. And here we can see red blood cells, 7 microns, which are even larger than bacteria, but you can look with just a tiny bit of pressure, say a patient blinking hard or rubbing their eye, you can see how blood can enter into the eye and inflow of extraocular fluid where there may be contamination into the anterior chamber. A second patient where you can see the incision area right at the limbus where there's some blood from the conjunctival vascular arcade, but again, with just minimal pressure, there's inflow of extraocular fluid into the eye, and this is the proposed mechanism. So clear corneal wound infection can occur, and where we are in the subtropical area of Florida, we have to be very careful. Like in this case seen recently, where the cataract surgery went technically very well, but approximately 2 weeks afterwards, the patient developed pain, redness, decreased vision, and now you can see here this severe suppuration with branching filamentous-like hyphae in the stroma, and cultures disclosed a heavy Aspergillus fumigatus in this case. Now, how many here still perform scleral tunnels in select cases? So a fair amount, about a third of the audience. And the scleral tunnel has the same potential risk, even though it's more posterior, so it's less likely to open with minor pressure, but the same mechanisms can occur that can lead to opening. And you can have cases of scleral infection in the tract of the wound, like this case that was referred to me for severe scleritis 7 weeks out after an otherwise uncomplicated cataract surgery. There was worsening clinical condition, as you can see, and above at the site of the superior wound, there was this infiltrate. The smear disclosed no organisms. The culture, however, did grow Aspergillus terreus. And here we can see why this patient was referred, thinking there was a necrotizing scleritis, as you see above here, adjacent the scleral tunnel incision superiorly. But look at the tract inside going into the eye that was loaded with these hyphal elements, and the cultures grew the heavy Aspergillus terreus in this case. So How does this happen? Well, probably by the same mechanism as with the clear corneal incisions. So we have to be very diligent and treat these patients very aggressively. There's been a number of reports in the literature that have looked at wound infection and the sources of microorganisms, typically the eyelids, the conjunctiva, exogenous contamination with instruments or irrigating solutions, and even airborne source of infection. The onset of symptoms are usually days to months after surgery, and the microorganisms can be anything, but these are the ones in the literature, both gram-positive and gram-negative species, and we see a number of yeast as well as filamentous fungi that can cause this. It's a diagnostic challenge because there's a variable clinical presentation. Often the initial smears may be negative, and as surgeons, we don't like to think of bad things happening to us or to our patients, so there's some denial involved. So you have to have a high degree of suspicion, careful examination of the wound, go back to the history and find out where was the incision, what type of surgery was performed, and are there any systemic diseases associated. Detailed slit lamp examination, imaging is important with B-scan, ultrasonography. Confocal microscopy is very helpful in these cases, as is anterior segment OCT and even aspirating the material. So you have to think of other non-infectious causes that could cause sterile corneal ulcerations, such as scleritis or other autoimmune diseases, but there's no substitute for obtaining material and performing culture. Because it's a deep-seated infection, it's challenging. There's poor drug penetration, and it's even an early keratoendophthalmitis, so we have to treat aggressively based on the smear results, modified based on the clinical response and the culture results. And we use a combination of topical, intraocular, systemic, and even subconjunctival therapy. And sometimes you have to go in and surgically debride the material and perform a scleral patch graft or lamellar keratoplasty. And the eye bank has a patch that the glaucoma surgeons are familiar with, which is a semi-lunar cornea that can work well in these cases. So we want to prevent by avoiding. Now, one last case I'll share with you. This was an arcuate keratotomy that was performed with the femtosecond laser. Patient was doing well with the reduction of cylinder, but some weeks later came in with pain, and you could see the hyperemia adjacent to limbus, and there was an infiltrate, a multifocal infiltrate, adjacent the arcuate keratotomy. And performing a scraping and opening up the arcuate keratotomy, removing the material, you can see these gram-positive filamentous-like organisms that grew a heavy nocardia asteroides, and the patient was treated successfully with topical and systemic trimethoprim sulfamethoxazole and did well. So remember, with the femtosecond laser, sometimes you're not in the operating room itself, but performing the incisions outside, and don't let the guard down with aseptic techniques. Oh, I guess there is one final case. This is for Dr. Slamovic, a patient who underwent a combined phacoemulsification intraocular lens and endothelial keratoplasty with DSEG, and did well until 6 weeks post-op, where there was this tiny little dot that you can probably see, Alan, in the center of the pupil that was of concern and of suspicion. And here we can see it highlighted. So now you have a problem where there's this tissue and there's an interface opacity sandwiched in the interface. And here there's a donor to host transmission problem. And you can see the OCT where now there's this infiltrate deep in the cornea. So what do you do? Well, you can pass a 6-0 silk suture through the area, carefully, sterilely cut the silk suture onto the media in order to obtain material. However, the therapeutic challenge is you may have to remove this graft and treat very aggressively, because we now have a space that has been unfortunately invaded by the bugs, and this is a real challenge because often the media do not protect against contamination. And this was the information of the donor, a 63-year-old who had bronchitis pre-operative, pre-death, pre-mortem, and family reported pulmonary candidiasis. And this grew Candida glabrata from the eye as well as the patient. So eye banks are now trying to screen more effectively and work with the team to report any cases. There's been criteria for absolute contraindications to donors, death of unknown cause, active bacteria or viral meningitis, fungal endocarditis, intrinsic eye disease, leukemia or disseminated lymphoma, and communicable diseases such as human immunodeficiency virus, hepatitis B or C, syphilis, or septicemia. The future is probably going to be changing the storage media, and already some of the eye banks are including antifungal into the media, whereas traditional storage media does not. So there's work being done now to supplement and augment the storage media to avoid this. So in summary, atypical corneal infections are rare, but possibly can occur with cataract surgical interventions. You need a heightened awareness, and clinical pattern recognition is necessary in these unusual presentations. Ancillary diagnostic testing and microbiologic evaluation is required in order to manage these cases successfully. Specific, highly aggressive, extended, prolonged antimicrobial therapy is essential for success, and often not just medical, but surgical debridement to debulk the infection may be needed. So thanks very much.